Hi, this is Dr. Rick Troutner. I'm the medical director of Bay TMS, and I'm here to talk to you today about TMS, or transcranial magnetic stimulation. This is a treatment for depression, and in particular for people who have not responded well to other treatments for depression. We'll be going through some of the background issues about depression, and then some of the factors of brain physiology and chemistry. Finally, about TMS itself, and then a few words about our response to date. Major depression is a major disease burden worldwide. There are 17 million US adults with major depression. It is one of the top 5 causes of disability, and 1 in 5 teenagers suffer from depression. Worldwide, the prevalence is 4.7%, and the World Health Organization predicts that by 2030, it will be the leading cause of disease burden worldwide. There is also a high rate of recurrence despite ongoing treatment. 60% of patients recur after 5 years and 85% over 15 years. In addition, anxiety disorders, which commonly co-occur with depression, are prevalent in 40 million adults, and often anxiety symptoms respond to TMS, as does depression. Antidepressant medication has been around since the 1950s, and we have a great deal of data about it. The most comprehensive study to date was called the STAR-D study, completed and published in 2006. The results were disappointing. They found that of patients in the first level of study, 27.5% achieved remission, which meant that nearly 75% did not. Those who did not went into the second level of the study, and of those, only 21.2% achieved remission. Until after a patient had failed 3 prior treatments, they had only a 6.9% chance of reaching remission. It appears from this study that antidepressants become increasingly less effective with each subsequent trial and increasingly poorly tolerated. Let's take a step back now and discuss how the brain works. We now conceive of the brain as an electrochemical organ. That is, it's a combination of neural cells, or neurons, and various chemicals in which the neurons are bathed and with which they interact. We can alter brain activity either chemically, as we do with medications, or electrically using neurostimulation. That is what TMS does. First, though, it may be helpful to review how neurons communicate. There are trillions of neurons in the brain, which carry many different kinds of messages. All neurons look approximately like this schematic diagram shows, with a long body and active ends that connect to other neurons. TMS acts directly on these neurons by stimulating their activity. When the neurons are stimulated, they release neurotransmitters at the synapse, which go on to affect the subsequent neuron, and so on. In this way, TMS directly stimulates neural pathways in the brain, which leads to lasting changes in the brain. What is TMS? TMS stands for transcranial magnetic stimulation. It is the application of a repetitive, alternating magnetic field to the target area of the brain. It directly depolarizes cortical neurons, which are part of brain circuits that are known to be affected by depression. It stimulates these circuits directly. It then causes release of neurotransmitters into the limbic system, which are the deep structures of the brain responsible for mood and mood regulation. Persistent antidepressant effects are thought to be due to long-term potentiation through something called synaptic strengthening. This diagram shows how transcranial magnetic stimulation affects the brain. We stimulate an area of the prefrontal cortex, which then communicates to deeper structures in the brain, releasing neurotransmitters and then feeding up through the brain again through various circuits affecting mood. This is a functional MRI from the Mayo Clinic that shows a depressed brain on the left, which is very blue, meaning that it is physiologically inert or not very active. When that brain recovers from depression, it looks like the brain on the right, which is now very much more active physiologically. This is the change we attempt to bring about with TMS. Going back to the STAR-D study, you may remember how many patients dropped out of the study due to antidepressant side effects. This slide compares the two treatments as far as side effects. On the left, drug therapy causes many side effects which many patients find intolerable. Primarily, patients are concerned with effects on weight and sexual function, but there are many other side effects as well. On the right-hand side, we really only have to deal with some mild scalp discomfort. There is a seizure rate due to TMS therapy. It is unclear how frequent it is, but it is very infrequent. It occurs less than 0.001% and appears to be significantly less, in fact, than the seizure rate due to antidepressant medication. TMS therapy is delivered using a number of different protocols, which are ways of providing the treatment. The stimulation is either done intermittently in trains or bursts of stimuli, or through continuous stimuli. These are also sometimes referred to as high-frequency or stimulatory treatment versus low-frequency or inhibitory treatment. The target area is usually the dorsolateral prefrontal cortex, either on the left side in the case of high-frequency treatment, or the right side for low-frequency treatment. We deliver several thousand pulses per treatment session. Typical course is 5 times per week for 6 weeks or 30 sessions. Each session is 20 to 30 minutes in length. At Bay TMS, we began using TMS shortly after it was approved in 2008. We analyzed our first 500 patients, and this is what we found. Bear in mind, this is a naturalistic study. It is not controlled, and there is no sham. It is purely our results in our clinic, seeing whichever patients came in the door and were appropriate for TMS. Female to male ratio was 63% to 37%, which is fairly common in depression studies. There were 95% had major depressive disorder and 5% had bipolar depression. In order to track our success, we use rating scales and apply research criteria to our results. We use the PHQ-9, which is a scale the patient completes, and the MADRS, which is a scale the rater or doctor completes. And we use the typical cutoffs to determine the rates of response or lack thereof. So using these criteria, 33% of our patients achieved remission, which is by definition a lack of depression. 29% achieved a full response, which is at least a 50% improvement in their rating scales. And 20% achieved a partial response, which is anywhere between a 25 and 50% improvement. Just 13% of our patients had no response, and 5% withdrew from treatment. These rates of response must be considered in light of the fact that these were very treatment-resistant patients. These are patients who had typically failed many medications over many years. And if you remember what the response rates were in the STAR-D study, by the time someone had failed 3 antidepressants, their chance of responding was just 6.9%. Here you can see it's far greater than that. I am showing you a slide of a patient we'll call Bill. As just one example of a fairly typical treatment course, he had scores on his MADRS that were very high in the very severe range at the beginning of treatment, as well as the PHQ-9. You can see that they dropped considerably by week 3. He then had a little bit of a recurrence or a mini blip in his symptoms, which is not uncommon during the treatment course. And then finally, by the end of the treatment, which for him was a full 8 weeks of treatment, he was down very low in the remission range of PHQ-9 and MADRS of 1. We followed him for a year, and he has remained in remission during that time. Another way to think about our results is to ask how many people can we help with TMS? If there are 10 patients who come to us saying they are suffering from severe depression and have failed to respond to many other treatments, 3 of them will leave in remission, that is, depression-free. Another 3 will have a full response to treatment, that is, more than 50% symptom relief. An additional 2 will have a partial response to treatment. Less than 2 out of 10 patients will have either no response to treatment or be unable to tolerate the treatment. So who can benefit from TMS? Patients with major depressive disorder, when antidepressants are not providing full symptom relief for depression and anxiety, or if medications are causing unacceptable side effects that limit quality of life. Pregnant or nursing mothers who want to avoid medications may be appropriate for TMS. And finally, patients with medical conditions or other medications that would conflict with antidepressant medication. Until very recently, TMS was approved only for the treatment of major depressive disorder. Just in the last few months, obsessive-compulsive disorder has also been approved as an indication for the use of TMS. Other conditions that remain experimental but have shown promise in early studies are bipolar depression. You remember that we had bipolar depressed patients in our 500 first patients. Chronic pain, such as fibromyalgia. Adolescent depression. Anxiety disorders, in particular post-traumatic stress disorder. Auditory hallucinations and tinnitus. And attention deficit disorder and various addictions. I want to emphasize that aside from obsessive-compulsive disorder in this slide, every other condition is considered experimental and off-label, and all have shown some promising results. In conclusion, TMS is an effective, safe, and well-tolerated modality for the treatment of major depressive disorder. It may be effective in treatment-refractory or treatment-resistant depression when other treatments have failed. Contraindications are primarily ferromagnetic objects in the head or neck. These could be various implants or retained objects in the head, such as aneurysm clips or metal fragments. These contraindications are very rare, as you might imagine. Side effects are minimal, and generally the treatment is very well tolerated. Beneficial effects are enduring due to something called long-term potentiation, which is a more or less permanent, or at least long-lasting, change in the behavior of neurons in the brain. TMS is now covered by all major insurance plans, and obtaining authorization is usually fairly straightforward. Thank you for watching. If you would like to receive further information, please don't hesitate to contact us at baytms.com or call us at 510-809-1599.